their behalf. But welcome, everyone. I'm Pindi Chaga. I'm one of the directors at the ICO, and we're joined with Diego and Mervyn, our chairman and president. And it's our first ICO webinar, something that we want to roll out to all members as a CPD. So we hope that you enjoy this and you find it useful. All feedback is welcome, so please do email us. But I'm going to hand it over to Diego and Mervyn.
Diego, would you like to kick off?
Yes.
Francisco. Hola. ¿Qué pasa?
Okay. Hello, everyone. I hope you're doing well. And thank you for joining us for this first webinar with Mervyn Waldman. Just to let you know, he will be talking with, we're having a conference in April. You probably know about that. On the 22nd of April on Sunday, and a workshop on Monday, the 23rd, with Mervyn Waldman and Chris Campbell. Mervyn Waldman, in this workshop, he will be doing about can classical osteopathic treatment influence neurogenic inflammation, host defense and immunopathology via its effects on the peripheral nervous system. He will have a look to the current research findings in neurophysiology and the relevance for the osteopathic treatment. Well, it's a long title, but I'm sure he, the same as this webinar, is an introduction to this physiological world and, you know, kind of what is the scope of osteopathy. So I'll let you with Mervyn Waldman, and I hope you enjoy this first webinar. Thank you.
Thanks, Diego. I hope I'm coming through clear and loud and clear.
Yes.
I chose quite deliberately what I hope will be a very relevant subject, but one that is very rarely talked about, very rarely discussed in depth. And that is something that happens all too frequently to all of us, no matter how many years we've been in practice. And that is the reasons that may lie behind our failures. Not only our failures, but the often very psychologically difficult experience of seeing what seem to be relatively easy cases that would otherwise be expected to recover or improve easily, not necessarily improving, and sometimes getting significantly worse under our treatment. And people seem to avoid, or certainly lecturers seem to avoid discussing this subject for obvious reasons. No one likes to talk about their failures. But I think we ought to discuss it frequently and in depth, because it should significantly affect the way we treat and also affect our expectations. And I'll go into that in some detail over the next 10 to 15 minutes. And obviously hope to have feedback from you as to your own experiences or your own difficulties or your own impressions when trying to handle this very common clinical phenomena of patients that seem to be relatively straightforward, nevertheless not recovering or even doing worse under our care. So what I've jotted down here on a piece of notepaper in front of me are a number of factors that I personally think are significant in playing a part as to why patients don't get better and often get worse. And these are factors that I personally have seen in my own practice and hopefully over the years have started to recognize as factors that I need to improve on myself. They are still factors 47 odd years since I've been in practice that still come up in my daily work, not least in the hospital where some very difficult cases tend to arise. So I'm still making some of these mistakes. I'm certainly not infallible despite all these years in practice. But hopefully it's getting less over time. So what do I think are some of the main factors that tend to cause bad reactions in patients and a lack of success in helping them? I'm going to deal mainly with the element of pain, because that is probably the major factor that we are seeing clinically in all our practices. And I'll look at some of the factors that tend to possibly create pain responses in patients that need not happen. I think one of the things that we do wrongly or mistakenly is not give sufficient attention in our initial meetings with the patient, certainly during the initial diagnostic meeting, to really trying to find the source of the pain that is worrying the patient. Where is it being generated from? Do we really look carefully at where there are pain-generating tissues? Do we really try to find out anatomically where the pain is arising from? Or do we tend to run or dive too quickly into treating in the hope of discovering in the course of, let us say, the total body adjustment approach, where we'll find the cause of their pain? I certainly often have not spent sufficient time in basic orthopedic or neurological examinations to discover, at least initially, where the pain is being generated from. This is particularly important where patients will often come with multiple sites of pain, or pain that is dispersed over many parts of the body. And we can easily neglect finding out where they have significant orthopedic or neurological reasons for pain in some of these sites if we haven't undertaken a proper examination procedure before we dive into the osteopathy and the osteopathic examination. So I certainly feel we often neglect the neurological examination in depth and the orthopedic examination in depth at the cost of the patient. That's one factor. Because if we neglect a proper diagnosis, we will often cause the patient to feel worse when we start to try to treat. The other thing that often plays a part, I think, in the patient getting worse is the problem of overtreatment. It is very difficult for most of us to believe that the maneuvers that we employ when we think we have discovered dysfunction, maneuvers that seem and look so simple, will have an effect, a physiological effect. And I believe, strongly believe to this day, that until we each of us experience being treated when in significant pain after being injured, or where there is a disease process going on with pain as part of the clinical picture, until we are actually on the table as patients suffering acute pain or an acute illness, we will never believe how some of our maneuvers done accurately, properly, and relatively quickly can have an effect. Because when we practice on each other as students or as colleagues, we're usually well, and the body doesn't respond in any significant way. In any significant way when we're circumducting a leg a few times, or using an arm as a lever, or gently rocking the spine and oscillating it. But when we are ill, whether it's through acute injuries or acute illness, the body is very, very sensitive to any mechanical interference, therapeutic or otherwise, and will react badly if we overtreat. But we're faced with a moral dilemma, I think, which is why we tend to overtreat. It is very difficult to believe that the patient will accept a treatment that lasts only 10 minutes, perhaps, or 12 minutes, when they're paying often significant amounts of money. We often feel, consciously or unconsciously, that we have to give them their money's worth. We can't believe that they will go away satisfied if we only spend 10 or 12 minutes, because that is all that their body can take at one session without overreacting. So what do I do clinically when faced with a patient in private practice? It's less problematic in hospital practice because they're paying much less, but what do I do in private practice with such a patient? Well, I fill in the half an hour that I devote to every patient, discussing, explaining what the condition is, discussing what I'm doing with the patient after I've treated the patient or before I've treated the patient. I spend time, I fill in the time valuably, talking about what they might do to help themselves at home, the environmental factors that may influence, the factors that may reduce their pain that they can perform or activate in the home setting. The time is spent therapeutically, but not necessarily by handling the patient who is so sensitive and whose body anatomy will react by way of irritating responses and hyperesthesia by being overtreated. But it's very difficult to know when to stop in the course of handling any part of the body. When is enough enough? When do you move on to another part of the body? When might you limit your treatment and cut the general treatment, the body adjustment, in half perhaps, and only treat the patient in one position perhaps because of the danger of overtreatment? These are all clinical decisions that are not easy, but they have to be made very often because the acute patient cannot bear being overhandled without reacting badly. The other factor that often causes, in my opinion, bad reactions and the patient getting worse is unduly forceful treatment. We use too much force. Rather than relying on the lever of limbs to apply the force, we often induce increasing force beyond that of the lever through our own body musculature and body weight. And it is surprising, it is truly surprising how light the classical osteopathic touch should be when treating a patient. Treating a chronic patient, but certainly when treating an acute patient. The touch is very light. It's firm, but it's very light. Which brings me to the next factor. If it is unduly forceful, the touch, you will cause pain during the treatment. And we often don't respect the patient's pain response while we're treating sufficiently. In other words, we often expect the patient to take the pain while we're treating them and to allow us to continue treating them despite our causing them often more pain while treating them. This, I believe, is wrong. It is wrong ethically and it is wrong clinically, in my opinion. Little John makes this point time and again in his clinical notes. We have a responsibility not to create greater pain. We are there to reduce their suffering. And that means on the treatment table, we have to keep a constant eye open to the patient's facial expressions and response. If at any time I get a response from the patient that suggests that I'm causing them more pain, I have a duty, a clinical duty, to find a way of nevertheless treating the part that I'm handling in a way that does not cause more pain. or leaving that part that is too painful quite alone and dealing with it at a later stage in the treatment protocol or at a different stage in the rehabilitation process. So keeping a constant eye on the patient's response while we're handling them, I think, is an essential aspect of preventing the patient getting worse. We are indebted to the pain response to know how much to do and how deep to go and for how long to be treated. I rely more on the patient's pain response than I do on my own hands and fingers. I cannot feel anywhere near as much as the patient feels when they're being handled and treated. So I ask the patient at the very beginning of the treatment, and during the course of the treatment, I remind the patient to let me know the moment I'm doing something that may be making the pain worse. There is a degree of discomfort that is acceptable, but it is discomfort and it's not pain. The moment you're making the patient feel greater pain, you are inevitably creating a greater or stronger inflammatory response in the tissues that are generating the pain. And that can last for days, if not weeks, if you make serious mistakes. The next problem that arises clinically that can be tragic is when we have acute orthopedic problems, be it a herniated disc or a meniscus tear or a shoulder with a tendinous tear, and we think we can treat the pain by applying leverages that in fact only increase the tearing. Again, we have to rely on the patient's pain response while we're applying our leverages to know whether we are likely to be making the condition worse. And it is very easy to make a herniated disc, for example, and turn it into a prolapsed disc by increasing the tearing of the annulus fibrosus because we're using angulated leverages which are not appropriate. For example, the use of sideline techniques, which increase the torque and torsion on the annulus fibrosus. And quite readily, I've done it a number of times and deeply regretted it, turned a herniated disc into a prolapsed disc because I did not work out the pathology that was underneath my hand and recognize that there are certain angles and situations where you do not apply certain techniques because they're too dangerous and where you have to employ maneuvers that don't involve torsion or torque that could generate increased tearing. And again, the shoulder is another example, and the knee is another example where you have to be very careful if you've got an acute patient with acute pain at those sites, and not necessarily through injury, if they're rheumatoid patients, or even marked degenerative cases, degenerative joint conditions. If you overdo the angulation or the circumduction or the torsion, you will create a far worse situation sometimes. It's particularly relevant where there are neurological symptoms. If there is already neurological deficit, that is reduced reflexes, ankle, knee, biceps, triceps, you are already walking on dangerous ground. You already have to presume that there is nerve root pressure, and it can be easily turned into something far more significant clinically if your leverages are not applied carefully. The other problem that often makes for poor response is the lack of relaxation on the part of the patient when we are applying our treatment. Do we really wait for the patient to relax the limb that we're going to try to use as a lever or a central anatomy of his body when we're trying to focus on the spine? Perhaps not. Perhaps we don't find the patients when patients are very difficult and find it very difficult to relax, and we steam ahead, nevertheless, with our treatment despite their resistance and their inability to relax voluntary muscles. That alone will cause exaggerated reactions and will jeopardize the therapeutic effect terribly. But it may mean that the first 2, 3, or 4 treatments are very limited in their therapeutic effect, because it'll take you 3, 4, 5 treatments to be able to get the patient to relax, to teach them to relax, to convince them that you're not going to do anything that hurts them or harms them. It's often fear that lies behind the patient's inability to let go. So you're going to have to convince them that they need not be frightened. And that can take time. So those are basically my opening remarks. I just want to spend a little more time before I open it up to all of you to give you some examples of how things have gone wrong for me in the past year. I picked out, in fact, 9 clinical cases I've seen that were awful clinical failures on my part in just 1 year. And those failures didn't arise because of some of the factors I've just been talking about, because of inappropriate technique or over-treatment. They arose because of a failure of diagnosis on my part. It was inappropriate treatment, given the pathology that was taking place in these individuals. And it's interesting, if you go back to Still on Little John, both of them insisted that your first priority as osteopathic physicians was diagnosis. And that the trinity on which osteopathy rests, the tripod, the 3 legs on which it rests, are anatomy, obviously, physiology, but terribly neglected in our osteopathic studies, pathology. The 3rd leg is pathology. And if we truly were to try to understand the pathology going on underneath the symptoms the patient is complaining of, and behind the signs that we can detect during our diagnostic examination, then I think we would do far better than we do at the moment. And all the cases I've written down, jotted down in front of me here, all 9 cases were a failure on my part to properly diagnose the pathology on the hand. Let me give you a simple example. And Pindi, please, and Diego, please butt in if I'm extending over time.
No, it's fine. Yes.
Okay. The first case was a woman I've been seeing recently who hasn't been able to sit for nearly 20 years because of coccydynia. The pain has been so severe that when she does try to sit, she has to lean right over onto one buttock. She has to bring major cushions with her everywhere, and only then can she sit for any length of time. 20 years with coccydynia. She has tried and been treated in every possible manner, including significant numbers of epidurals, as well as local anesthetic injections, none of which has helped. I tried to help her over a period of a trial. I was clear that it was going to be a trial. I told her that very clearly, because chronic pain is very difficult to help. I said, look, let's try a trial of 8 treatments. In the diagnosis, osteopathically, there was nothing significant. I certainly couldn't reproduce the coccygeal pain by way of any provocative leverages. But I thought to myself, as often we do in osteopathy, that maybe something will emerge in the course of going through the body adjustment procedures that will bring out the possible reason for the pain. After 8 sessions, it was clear nothing was happening, neither getting worse nor better. She decided to meet with one of the psychologists in the department. This was a hospital patient. And we had a meeting in which I was called in together with the psychologist. And the following emerged from that meeting with the psychologist, something I did not know. 20 years ago, a few weeks before the onset of this terrible pain, her mother died. Not only did her mother die, her mother also had suffered from the same symptoms, severe coccydynia. The problem was, and she readily admitted it to the psychologist, she had not yet completed mourning for her mother. She was still mourning the loss of her mother. Her mother still was on her mind almost daily as a loss she had not overcome yet. The next was a patient in her 80s, an elderly lady, otherwise fit, but had become housebound with increasingly severe low back pain. No neurological symptoms, but the pain was increasingly disturbing her sleep. I attended her at home and said, I'm not sure where her pain is arising from, but let's try and see what happens and whether you respond to my gently articulating anything that may be somewhat dysfunction in the area. She got some relief in the initial treatments, and she was relieved when supine. After about the 5th or 6th treatment, she was definitely getting worse. And her sleep was increasingly disturbed, which, as you probably realize, raises alarm bells, certainly red flags. I suggested that she go to a hospital, as did her family doctor, and on CT, a benign meningioma, not malignant, a benign meningioma was discovered at the level of L3. That was clearly the cause of her pain. It was removed with a simple operation in this elderly lady, and she suffered no further pain after it was removed. I failed to think about there being a meningioma there. Let me give you one more example, because I don't want to hog all the time. A young boy of 10 was brought to me with a painful hip. He'd been jumping and running and exercising and playing football, and he fell, and that seemed to be the cause of the painful hip, and it was significantly painful, so that he was limping. I began to treat him weekly. There was no improvement. In fact, it was getting worse. Did I find anything osteopathic? No, nothing significant, nothing major. Yes, I could exaggerate or make the pain worse on adduction and circumduction of the painful limb. But beyond that, there were no other signs as to why the fall or any trauma that might have caused the pain shouldn't have recovered by then. As he was getting worse week by week, I suggested he go back and get an orthopedic consultant's opinion. CT was done, and a clear diagnosis that the boy was suffering from aseptic necrosis of the head of the femur. And was operated on within a couple of weeks of that diagnosis, because the opinion is that if you can operate early, you can save the young person's ability to walk without undue limping, and the growth of the leg will not be unduly disturbed. And that was the clinical decision that everyone agreed should be taken. So again, a failure on our part, or our need to get on and treat the patient as quickly as possible, often prevents us from thinking clinically, from thinking medically. And that, I believe, is another significant factor in us often causing perfectly good patients to get worse. So now I'd like to open it up to everybody and be happy to hear comments or contributions from anybody else. Pindi, would you like to step in?
Hi, I'm back as well. Hello. Thank you. We do have a Q&A coming through. Tim Barrett asks, my pathology Bible is this one, Pathology, Implications for a Physical Therapist, Catherine Cavallaro Goodman, Kendoris Fuller, and he shared a link. So there's a comment box question, and the link is also in the chat box if anyone wants to click and...
That sounds marvellous. That sounds a wonderful book. Yeah. I should definitely look for it, yeah.
Came through. So if you have any questions or comments, please type them through into the chat box or into the Q&A box and we'll read them out. Tim was just saying it's a reference, that's all. Thank you, Tim, for that. So that's in the chat box if anyone would like to click on it. Neil Fraser, Tim, is asking the name of the book. I think it's called Pathology Implications for the Physical Therapist.
Yeah.
Sorry, Tim, the way you've typed it, it hasn't gone through to all attendees, so I'm just going to copy and paste it. There you go now. So you should be able to see that. We've had a few people join us while you were talking, Mervyn. So if you all go down to the bottom of your screen, there's a chat box there. And if you go onto the chat box, make sure the blue panel says all panelists and attendees and type your comments in there, then we'll all see the comment.
Mervyn, can I ask you a question?
Yeah, fire away.
It's about the type of patients that you receive there. I guess we see differences in Spain from England as well. Many patients here, by the time they come to see us, they already have resonance, x-rays, they already have done all that. In England, we didn't see like that. They came first to us. I don't know how it's in Israel.
Well, in the hospital, they often do have a full workup before I see them. And so that's a great help. Yeah. A very great help. I love that situation because my medical colleagues are far better than I am at diagnosis, far better. But in private practice, that isn't the case. In private practice, they're often coming to me as a first provider, and that leaves me open to making serious mistakes. Yeah. I deeply regret, to this day, not having a medical degree first. I deeply regret it. I will never in my life make up for the lack of clinical training and diagnostic training that I would have had I gone through medical training, including department by department experience and gaining the diagnostic skills that one does by doing that.
Okay, yeah.
Just another question, Mervyn. That was a very nice introduction to the features that create a pain response in our patients, and I think that's you made a very clear explanation of what we find out every day in clinic. It's just I wanted to you can cover these patients that are unable to relax on the table. How do you deal with them? Because sometimes they are very difficult and I don't know.
Yes. Very difficult. There are two ways I do that. Either I decide, right from the beginning, having already noticed how tense the patient is, to actually teach them relaxation technique on the table or in a chair before they actually get on the table, how to simply learn to relax, which is, for me, the simplest technique I've ever found. There are two approaches. One is called, it's a very long name, but it's very well known in medicine today, called mindfulness meditation, which is extremely simple, and you can learn it on YouTube to then teach your patients. It's very, very simple. They sit in a chair, sitting upright in a chair, the eyes are closed, and they learn to concentrate on the breath. In so doing, especially the outward breath, the level of tension in all the voluntary muscles of the body quite quickly goes down. And when they continue practicing that breathing, that concentration on the breathing, when they lie down on the table. That's a very easy way of teaching a patient to relax. It can still take 3 or 4 weeks for them to get good at it. The other way is one that has been taught for many years to mothers before delivery of their child. They're often going to these classes for a month or two before the delivery to learn to relax, and it's called paced respiration. Paced, P-A-C-E-D, respiration. And again, you can find it on YouTube. And that's a very simple procedure where the mother, or the patient in our case, counts down from 5 to 1 slowly after they've expired, after they've let the outward breath finish its expiratory cycle. So they breathe out and then they count from 5 to 1 before they breathe in again. They elongate the expiration. But you can read that up in YouTube in more detail. That's another simple way. So I may actually teach them first to relax before expecting to give them any kind of treatment. Or if the treatment is necessary, because they're obviously in a lot of pain, which is why they've come to me, or they're unwell, then I put them immediately on the tummy, if that's comfortable, sometimes with cushions under the body to make it more comfortable to turn their head. I don't have a hole in the table for certain reasons. But on the tummy, most patients will allow me to apply inhibitory techniques to the erector spinae muscles without any great difficulty. They won't necessarily be tensing their erector spinae. And I make sure that their limbs their arms particularly, are loose over the edge of the table. They're not holding their hands in a fist. And often that is good enough to begin treatment, at least in the prone position. Or I may treat them entirely in the sitting position. Often they will be far more relaxed and less frightened in the sitting position, where they feel less invasion of their privacy than if they're lying exposed with their bodies up in the supine position or in the prone position. So often therapeutic position of sitting is easier to get them to be treated in for relaxation. But most often I actually use the body adjustment procedure as a relaxation technique. I spend a little time waiting for the leg to relax before I can circumduct it properly. I tell the patient the moment they're letting me do it better, yes, that is better. I'm giving them immediate feedback, immediate sensory motor feedback by way of telling them, yes, that is better, yes. I try never to say anything negative when they're not succeeding. I don't say to them, you're not relaxing, or that's not good, or, can't you do better? Never try to help the patient by using negative comments. Always make it positive. Mm-hmm. Always suggest, let's try a little better than that, or that wasn't bad, let's do it a little more easily next time. There are ways that you can use the body adjustment procedure as a relaxation technique.
Yes, I totally agree with that. Those positive comments, they are always better for the patient. Otherwise, too many negative things, pain, and stress.
But let me just make one more point. Your demeanor, your voice, your eye contact, and most important, the way your hands actually touch the patient are probably more significant than anything else in getting them to relax or getting them to tense up. There is a clear, I've said this many times in the past, there is a clear osteopathic touch. And it's very clear the difference between someone who has it and someone who doesn't have it. It's warm, it's gentle, but it's firm. It's not invasive, but it's definitely, what's the word I'm looking for? It's definitely authoritative, but without being invasive and without being hard. It's authoritative but calm. And it's all wrapped up, all those factors are wrapped up in just the touch, the way the hand envelops the part under it, the way the hand contours itself to the shape of the part of the body anatomy under it. It becomes one, exactly like a sculptor working with clay. The sculptor's hand, or the potter's hand even more, becomes one with the clay that he or she is molding. And if we can see our work basically as an attempt to mold, to persuade, then the hands work differently than if we're trying to move things as the chief aim of our work.
I actually did a CPD on this very thing on Wednesday on the biopsychology of osteopathic treatment and how our intentions, how words, our environment, our time has an influence on the patients we are treating. And as you said, very specific. And equally, if we're not careful, we can be quite negative in our mannerism and have a negative reaction in patients who will not get better because that's what we're feeding them. Oh, your symptoms are really bad, or your symptoms are going to take a while. And that's what they're absorbing.
Yes, definitely. Everything counts. Everything. From the lighting in your room to the way you greet the patient when they come in. What do you do when they're undressing? Do you make it easy for a woman to undress without embarrassment? So many little things that can add up to make a difference as to how they're going to let you to treat them. How they're going to let you treat them.
Yeah. Totally agree with that. Yes.
Yes. Me too. Another question, Mervyn.
Yeah.
We see here all the time as well. Is with medication. Patients come with a lot of medication, and we know that sometimes it gets in the way, and we cannot do anything about that, really.
Yeah,
I don't know how much you mention patients about that, or we just leave it to one side, or I don't know.
Well, usually a lot of the patients we see are already self-selected. By that I mean they're already coming to us because they want an alternative to medication. Or invasive injections. And they're already half on your side. And I certainly encourage them, with or without the doctor who's prescribed the medication, but once I'm getting into treatment, perhaps after the second or third treatment, I'm already trying to get them to reduce the dosage, slowly. And I explain to them, I need a clear clinical picture. I need to know more clearly whether what I'm doing is helping. And I need to also know how deeply I can go in my treatment. And I can only know that if the medication that you're taking, which is often very strong analgesics, isn't covering the picture, isn't preventing you from telling me that I'm doing too much or I'm going too deeply. So most patients understand that and are willing to take a little bit more pain if they understand that I need a clearer picture, a more realistic picture of what in fact is happening because of the pathology that they have. So slowly but surely they will often be happy to reduce their dosages. I will often get them to do something else to alleviate the pain. And I extensively, for example, use ice, where I think the pain is probably coming from a significant inflammatory reaction, be it the knee or the shoulder. I will get them to put ice packs on for 15 minutes, have a break for 2 minutes to just rub the skin to prevent any skin damage, obviously with a cloth between the ice pack and the skin, and then again 15 minutes, so that they've done pretty much half an hour to anesthetize the area that is causing pain because of the nerve irritation that is a consequence of the inflammation. And that will often be sufficient to numb the part that is causing a lot of pain for a few hours. That would be a very important alternative for me, including acute disc or facet pain syndromes. Ice can be often very, very effective, especially if there's someone there to help them do it.
Okay.
We forget how sometimes some of the simplest things can make a difference. When do you use heat rather than ice? That's a big question clinically. And there are some pretty simple guidelines. We don't have to go into that right now, but those are factors that I will certainly include. I include therapeutic positions that could ease pain. Cervicalgia or back pain can often be eased by lying on a carpet or a yoga mat with the legs at 90 degrees on the seat of a chair for 10, 15 minutes at a time without moving, just being in that very comfortable position. Or the Muslim praying position, where they're on all fours. There are gentle movements that I will teach them quite early on that are not painful, but can certainly help relieve pain. We forget that movement can relieve pain, if for no other reason, that it will encourage lymphatic drainage of the inflamed part. It will encourage the movement of inflamed tissue fluids and therefore reduce the edema that is often a major part of pain, including edema that's building up in the spinal canal and the vertebral foramen. So teaching the patient while lying in bed, if they can't even move out of bed, to simply move the legs from side to side, and the legs are together at 90 degrees, and the knees are up. Just gentle movement every 20 minutes or half an hour for a minute from side to side can make a difference in relieving pain, even in the most acute patient. You may not be able to do anything else. We forget the simple clinical things that make a difference in the acute patient.
Okay. Yeah.
Okay. Thank you very much. I think we have been 50 minutes doing this webinar. I don't know if we have any other questions, but I would like to thank you, Mervyn, for this talk. In my opinion, it shows a very humble approach to osteopathy. There is no magic osteopathy. There are no tricks in our techniques. It's just it's the way we work. Yeah, so slowly, steadily, and we should all learn from your examples that you gave to us that we have to pay attention every day to every single detail, as you say, from the moment we welcome the patient, how we take the case history, the clinic, the diagnosis, and the treatment. So, from my opinion, that's very, very interesting.
Can I just finish with a final sentence?
Sure.
We must listen to the patient. And by listen, I mean listen clinically. All of us don't listen sufficiently to what the patient is saying and what's behind what the patient is saying. They are giving us, I would reckon, 80% of the clinical clues that we need, whether to go in and help or withdraw, whether to go in carefully and slowly, or whether we can go in more quickly. They are giving us an enormous amount of information if we listen and if we ask the right questions too. Can I just ask you, Pindi, what would be wonderful?
Before we finish, though, David would like to make a comment and reflect.
Yeah.
I want to switch his mic on so he can talk and we can all hear him.
Yeah.
David, you are audible.
I'm live. Can you hear me?
You're live.
Marvellous.
Yes.
Well, first of all, I just wanted to echo Diego's comments in thanking you, Mervyn, for your frankness on this sort of rarely talked about area. And I have to say, personally, it's very sort of comforting, reassuring to know that someone of your experience still has struggles with difficult cases and unexpected reactions. So thank you for that. And I think it got me reflecting on my time as a new graduate. I was initially at John Wernham's college at Nescott over the time when the RQ status was a problem and they were closed down. And I ended up moving to the BSO. And I moved to the BSO with an absolute love of classical osteopathy. And I was a little bit of a hybrid, I suppose. In that the classical training to begin with gave me a massive grounding in patient handling and the treatment approach, whereas the BSO, the British School of Osteopathy, was very much more of a sort of a technical, more of an academic start to the course. So we had quite a bit of catching up to do orthopedics-wise when we changed the colleges. But I remember in the early days, I was so in love with, and I still am so in love with classical osteopathy, and I think I sing its praises. And I used to think I'm going to body adjust absolutely everyone, come what may, whatever happens, whether they walk in with an acute this or an acute that, I would body adjust. And I realized very quickly that actually, my agenda wasn't. I was looking to sort of impose something that I thought was the right thing, rather than really listening. And I think it was fascinating to hear you. That I think we can all, I certainly can, and we all be guilty of maybe not really listening to our hands, and like you said just at the end there, really listening to our patients and really recognizing their subtle signs and subtle little words here and there that can point us in the right direction. So I just wanted to add a few little bits in on that.
Yeah, and of course the listening is also with our hands. Do we really, really listen each time we handle a patient, or are we getting into a routine? That terrible word, routine. It's a great danger in classical osteopathy, possibly the biggest danger. We get into a routine and we don't individualize the treatment.
Indeed. Yes.
That could be for another hour of talking, yes?
Absolutely.
Okay.
Pindi and Diego, just one last thing. How this may help the ICO. We're all ICO people, I believe, that's linked on today, that will join up. I think, I don't mean to say so out of any degree of pride, but I think the subject is a very sexy subject, a very catchy subject. I think it can be used to get non-ICO members, non-ICO osteopaths, interested in ICO. So if there's any way that a recording of this afternoon's work can be available to BSO people, undergraduates and postgraduates, or anyone else on the register, on the osteopathic register, I think would be a worthy effort to get it known that it is available, with the title being, I think, a catchy title.
That could go on in YouTube then. Yes. Very good.
Yeah, we can post it on YouTube or post it on a cloud. We're kind of working it out between us.
Yes.
on which site to post it on.
Yeah.
Thank you. Well, I don't want to wrap it up, Diego, because Diego, you've got conference details to share and conference dates. We've got a conference coming up.
Yes, it's just that the conference. This was like an opening for the conference that we have, as I said at the beginning, in April on the 22nd and 23rd. So we will have on the conference day we will have Mervyn Waldman, Chris Campbell, Stuart Korth. Then we'll have Dr. Wilfried Janning from Germany, the professor in physiology, and from Canada, Pascal Grulot. And they all will be talking about the title of the scope, exploring the scope of osteopathy. Each individual will give his own view about osteopathy. They are all very experienced osteopaths. As I said, Professor Yannick, he will be talking about the autonomic nervous system, and Pascal Goulot, we will be talking about the vagus nerve, a research that he has been doing on the vagus nerve. So I think it's a very interesting topic, and I truly welcome everyone to join us on the 22nd of April. And then the day after, we will have, as I said, a workshop, a whole day with Mervyn Waldman workshop, and Chris Campbell, he will be in clinic, Chris Campbell and Mervyn Waldman in the lecture room, guiding us through some principles and neurophysiology and some techniques maybe. But it is an inspiration weekend for everybody. I hope it is.
Yeah.
Wonderful.
Thank you.
Thank you, Mervyn. Thank you, Pindi. Thank you, everybody, for joining us.
Thank you.
See you soon. See you soon.
This makes the ICO worldwide osteopathy like we like.
Yes, and it's accessible, so that's what we really want. Everyone is kind of accessing,
Very easy.
joining the ICO colleagues and maintaining contact and connecting without having to fly over to Dorking every time. So it's another medium that we want to introduce. So your feedback will be absolutely invaluable. If you could send us an email, either respond to this link or respond to the emails that have come out from ICO Front Desk, and give us your feedback on improvements or how you found the whole experience. It'd be beneficial to us, and then we know what to do for moving forward to bring you some CPD and some connection for members.
Very good. Yeah.
Okay.
Okay.
Thank you so much.
Have a good weekend.
Thank you.
Bye.